very first seminar under the series of evidence synthesis for global health. Just to tell you that we'll be having a couple of more seminars coming in a few months. So till then, stay tuned. Quickly introducing myself, I am Samiksha. I currently work with TGI in Meta Research and Evidence Synthesis Unit as a consultant. Let me now take this opportunity to welcome our today's fireside chat host, Dr. Soumyadeep Bhaumik. So, Dr. Soumyadeep Bhaumik is a co-head in Meta Research and Evidence Synthesis Unit (TGI). He's a medical doctor and international public health specialist working on evidence synthesis, meta research, health policy, and injury. And his work is focused on snake bite and drowning. He has been working on employing a diverse range of methodologies to ensure fit for purpose approaches to inform policy, practice, and future research. His work has informed multiple WHO guidelines and technical documents and national policies. So, a very warm welcome to you, Dr. Soumyadeep. And before we move ahead with the presentation, I would like to play a short video clip which will give you a glimpse of the work that we did during our COVID times, our team of rapid research responders, and the work was supported by Alliance for Health Policy and System Research, World Health Organization. So I would now like to hand it over to Dr. Soumyadeep.
Thank you, Samiksha. It's really a pleasure that we have a meta research and evidence synthesis unit in the George Institute for Global Health. And I thanked Dr. Zohra Lassi because she agreed to deliver our first inaugural seminar and talk to us about the work she has been doing in this space for more than a decade. But before we go to talk about these things, I think we'll start by acknowledging our roots of the Meta Research and Evidence Synthesis Unit, which essentially lies in the work we have done in the Alliance for Health Policy Systems Research project on rapid responders. And we'll just very quickly share a short video on what we did in the project and why this is important.
In policy making, everything has to be done yesterday. Policymakers always need information contextualized. The turnaround time is fairly quick. We need to have capacity to be able to do this kind of rapid synthesis. So I think having more institutions doing rapid evidence synthesis would be very, very helpful.
We want to be able to pose important policy questions based on the best available evidence, other countries' experience, and to facilitate policy discussions and to come up with effective and efficient solutions.
So, and because of this issue of making evidence available for decision making at the right time, it's very important, as many of these policymakers highlighted, is having rapid reviews or rapid evidence synthesis. This is just like any other evidence synthesis technique and has the same stages. But what we do is kind of optimize this work to expedite it by two main areas. One is, of course, on the human resources and the intensity of doing work. But also the other end is also about using technology to facilitate the process. And while we had this unit from 2019 onwards with support from Alliance for Health Policy and Systems Research, we really got to show our work during COVID-19. And we'll just go to the time when we talk and let's listen about what happened during the COVID-19 outbreak that happened in March 2020.
We have 1 million community health workers. We have one in every village, and she's called the Asha. For 15 years, they've been the face of the flagship program of India, which is the health system strengthening effort.
These community health workers are the ones going door to door for immunization or for maternal health services.
They are actually the one who bridges the gap between the health system and the community. So I think protecting them should be a priority.
So while this was going on and there was a need to hit the ground because ASHAs were already working on there, the government put us a request through the National Health System Resource Center requesting us to understand what roles community health workers had played in previous pandemics and how we can equip them in terms of training, governance, informations, and equipment. And we were given a timeline of 3 days, something we had not done ever before in terms of rapid evidence synthesis. And this is what happened while we were working on it. Usually the systematic review takes 6 months to 2 years. In terms of the rapid evidence work we had done before, it's usually around 4 to 6 weeks.
Literally, we gave them a weekend. It was a Friday evening. We reached out to them, and this one had to go out Monday morning. We had to hit the ground running because the ASHAs were already out there in the community. And so we needed the evidence synthesis within that time.
So it was like, okay, we have to do this. I was quite challenged that this is something which we have not done before. But as they say in a pandemic, timing is everything. I'm just sharing some more experience around what happened during that time.
It was like around 12:30 in the night. The report had to go at like 7:30 next morning. I was very exhausted and I kind of drifted away for a moment to looking at the bigger picture of what is at stake if we are not able to deliver it. I mean, these decision makers were going to use it for our community health workers, and their work at that point of time was very crucial. And that's what kept me motivated and awake.
And yes, we were indeed able to do this within the given period of time and have the report submitted. And this is available in our website and through the link that is being shared in the chat box. And just to inform that this report has led to a publication later in a more fuller rapid evidence synthesis that was published with more details and analysis, and has also informed some other guidelines both by the WHO and a few other national government at that space too. Thank you for being with me in the short video, and we'll go to the main agenda. Over to you, Samiksha.
Yeah. Thank you so much, Soumyadeep, for the video. And now, before we move ahead with the presentation, let me take this opportunity to welcome our today's speaker, Dr. Zohra Lassi. So, she is an internationally recognized epidemiologist. Her work identifies interventions to improve reproductive, maternal, newborn, child, and adolescent health and nutrition in disadvantaged settings by advancing knowledge in public health practice and translation into global health policies and guidelines. Her work has been recognized through numerous national and international awards, including the NHMRC Early Career Research Fellowship Award and the recent NHMRC Emerging Leadership Award. She is also the recipient of the Women's Excellence in Research Award from the University of Adelaide and the Healthy Development Adelaide. She has also been conferred with the 2020 Episteme Laureate Award from the Sigma Global Excellence. A very warm welcome to you, Dr. Zohra Lassi, and the platform is all yours.
Thank you, Samiksha, for the lovely introduction. It is a great pleasure to be here, and thank you all for coming here this afternoon. What I'm going to present, but before I present, let me share my screen, which is, I hope this is visible now. Okay, what I'm going to talk about is health and nutrition across the continuum of care for children and adolescents. So most of the work that I'm presenting here today, and I believe this one would be annoying you. Let me move it from here. All right. So most of the work that I am presenting here is from the evidence synthesis exercise that I've done over the career. And most of these work were externally funded or commissioned by World Health Organization. So in my talk today, I'll be giving you a global scenario of child and adolescent health and nutrition and the evidence from the evidence synthesis exercise that we have done over the years and how it informs the guidelines development. Okay, so let me start. Let me take control. Okay, let me start with giving you a global picture on neonatal child and adolescent health and nutrition status. The global progress in reducing child mortality has been remarkable. The global under 5 mortality rate has declined by almost 60% since 1990. So it was 93 per 1,000 live births in 1990, and it decreased down to 38 deaths per 1,000 live births in 2019. As a result, millions more children survive through adolescence today than they did in 1990. Now, against this backdrop of progress, the burden of child deaths remains high. 7.4 million children and young people under the age of 25 died in 2019 alone. Of those, 5.2 million children died before reaching age 5, and almost half of those deaths, that is 2.4 million, were among newborns. Now, apart from under 5 mortality, children aged 5 to 9 years accounted for 0.5 millions of all the deaths, adolescent aged 10 to 19 accounted for 1 millions of all the deaths, and youth aged 20 to 24 accounted for 0.8 millions of all the deaths in 2019. Now, compounding this tragedy, these children and young people died mostly of preventable causes. Despite this global progress, geographical disparity in child survival persists. Children in sub-Saharan Africa continue to face the steepest odds of survival in the world at 27 deaths per 1,000 live births, followed by Central and South Asia with 24 deaths per 1,000 live births. So a child born in sub-Saharan Africa is 10 times more likely to die in the first month of life than a child born in any of the high-income countries, or 12 times more likely to die than a child born in the region of Australia and New Zealand. If we look at the child mortality on global map, we can see that sub-Saharan Africa had the highest under 5 mortality rate in 2019, which was 76 deaths per 1,000 live births in 2019. That is equivalent to one child in 13 dying before reaching the age 5, which is 20 times higher than any child in Australia and New Zealand. If we talk about the deaths among adolescent and youth, again, the same countries have highest burden of adolescent and youth dying, followed by in South Asia. Now let's talk about malnutrition. Malnutrition can be undernutrition, micronutrient deficiency, or overnutrition. Now, when we talk about undernutrition, it can be a person can have underweight or stunted or wasting. Around 800 million people in this world are underweight, which means their weight is not according to their age. And approximately 3 million deaths under the age of 5 are related to being underweight. If we talk about micronutrient deficiency, which is inadequate consumption of minerals and vitamins, 2 billion people are affected by anemia, mostly because of iron deficiency. And vitamin A and iodine deficiency are the greatest public health concern globally. On the other hand, obesity is a major risk factor for chronic diseases such as diabetes or metabolic disorder, and approximately 2 billion adults and 41 million children under the age of 5 years are either overweight and obese. This map is actually showing the global distribution of double and triple burden of malnutrition. You can see that African countries are facing the triple burden of malnutrition, which means they have a combination of overweight, stunting, or anemia, whereas South Asia is facing double burden of malnutrition, that is a combination of overweight, stunting, or any other micronutrient deficiency. If we talk about the cost of ill health, we can see that the average lifetime lost earning associated with stunting per child is $1,400. Estimated economic losses in low and middle income countries from heart diseases or cancer or diabetes or chronic respiratory diseases is $7 trillion. The annual estimated cost to global economy of all form of malnutrition is around $3.5 trillion. However, the investment needed per child per year to meet the global targets for under 5 child stunting is only $8.5. This global map is actually showing the progress of Sustainable Development Goal, and we can see the same country which have the highest burden of neonatal child and adolescent mortality are far from reaching the target set for 2030 Sustainable Development Goal, that is Sub-Saharan Africa and South Asia. Now, the report and the evidence says that the progress towards Sustainable Development Goal is directly related to socio-demographic index of the country. So the higher the socio-demographic index, the higher the chances or the highest the progress of that country is towards meeting the targets set for Sustainable Development Goal. This particular figure is actually showing that this figure is actually coming from a report that reported the progress of 195 countries towards Sustainable Development Goal. And this figure is showing that 122 countries in this world have already met the targets set for SDGs. However, 20 countries which are there in the small box will be meeting the target set for 2030 SDG. However, there are 53 countries outside of the small box, mainly from Sub-Saharan Africa or South Asia, which are far from reaching the target set for 2030, and they require intensified efforts to meet those targets. Now, the need for better health and nutrition among children and adolescents are recognized in Sustainable Development Goal 2, which aims to end hunger, and Sustainable Development Goal 3, which aims to promote good health and well-being. However, improving health and nutrition goes beyond Sustainable Development Goal 2 and 3 and is linked to each of these Sustainable Development Goals that can play a transformational role in driving sustainable development. Similarly, achieving health and nutrition depend on the progress across many of the other SDGs, including those that aimed at providing clean water and sanitation, education, and gender equality. Now, this was a brief background on the child and adolescent health and nutrition and progress towards achieving the goals set for Sustainable Development Goals. Now, let's talk about the evidence-based interventions to improve the health and nutrition of children and adolescents. And most of these evidence are actually coming from evidence synthesis exercises. All right, so one of the work that I was involved in was to prepare a list of interventions and commodities across the continuum of care for improved reproductive, maternal, newborn, and child health, and this be prepared for World Health Organization. So in this exercise, we actually identified 142 interventions, 142 RM and CH interventions, and we identified 33 very essential interventions that you can see in this figure. So you can see that there are 33 very essential interventions across the continuum of care to improve reproductive, maternal, newborn, and child health. And then we also identified and distributed and classified according to different level of healthcare system that we can deliver these from. So for example, interventions that can be provided at all the levels of community, primary or referral levels, interventions that can be provided at primary and referral levels, some at referral levels only, and some at community levels. So after doing this exercise during my PhD, I took this work further and looked at specifically at those interventions that can improve the survival among neonates and children. So during my PhD work, I identified a total of 148 Cochrane and non-Cochrane systematic reviews on 61 reproductive, maternal, newborn, child health interventions. And of those, I identified that only 57 reported on either perinatal, neonatal, or child mortality. So this figure is actually showing the distribution of those interventions across the continuum of care and how many reviews we identified in each of those domains. And based on the evidence synthesis exercise and grade approach, applying grade approach, we identified some of the interventions that works, some that might work, and some where the evidence was still insufficient to make any judgment. So based on the grade approach, using the grade approach, we identified some effective intervention, some promising intervention where more evidence was needed, and some ineffective or probably ineffective interventions through this exercise. So these were some of the very effective interventions that can save the lives of newborns and children, and that includes early initiation of breastfeeding, hygienic cord care, kangaroo care for preterm infants, provision and promotion and use of insecticide-treated bed nets for children. We also identified some of the promising intervention, and that includes antenatal care, tetanus immunization in pregnancy, prophylactic antimalarial during pregnancy, case management of neonatal sepsis, case management of childhood infectious diseases, and home visit across the continuum of care. So for these interventions, the evidence was present that reported neonatal and child mortality. However, using the GRADE approach, those were not very high quality. Maybe they were low or very low quality. All right. Now, we have talked about the different interventions that worked across the continuum of care. We also did an evidence synthesis exercise where we looked at the first 1,000-day approach. So the research has dramatically expanded our understanding of how important is the first 1,000 days of life, that is from early pregnancy through the first 2 years of life, and is best known as a window of opportunity. However, it is also important to acknowledge that adolescents offer the second window of opportunity in which growth and development are faster than at any other time except the first year of life, which suggests that it is equally important to invest in adolescents because they are the future parents. So through this exercise, we identified that we do not have to confine to the first 1,000 days, but we need to go beyond these first 1,000 days and need to improve the health of adolescents as well, which are the future parents of the next generation. So while children have been included in national and international agenda, adolescents have been neglected. They are the foundational year. These are the foundational years of health and human development. And these individuals, as I mentioned, are the parents of the next generation. Therefore, investing in their health will have significant flow-on effects and provides triple dividends, that is for their health now, for their health in the adult life, and for the health of the future generation. So this actually emphasizes that we need to invest in adolescent health as well. And this is why we started another evidence synthesis exercise where we specifically looked at the different risk factors and interventions that can improve, how they can improve the health of adolescents. I mean, when we avoid those risk factors and when we improve and how we can improve the health of adolescents. So this particular framework actually showing the different risk factors and potential interventions that we looked through the exercise that we conducted. So we identified some evidence where we identified some intervention where the evidence was very plausible and robust for inclusion in any program, and those are the interventions that we have highlighted in green. Then we also identified some interventions where further research was required, and we identified those interventions and they are mentioned in the blues. And then we also identified some interventions where the evidence was still very inconclusive, and those are the interventions that we have highlighted in reds. So through this evidence synthesis exercise, we identified what intervention actually work, where there is some promising evidence, and where there is inconclusive evidence actually. Through this evidence synthesis exercise, we also identified the ideal delivery platforms that can augment the coverage of proven adolescent health specific intervention and provide opportunity to reach hard to reach and disadvantaged population. So through the evidence synthesis exercise, we actually identified which intervention works through which platform. So for example, sexual health education, we identified the evidence from all different platforms that equally works and was equally effective. Similarly, some of the intervention was specifically working through community-based platform or from school-based platform. So we not only identified the effective intervention, but the ideal delivery platform for each of those interventions as well through the exercise that we conducted. We, on a separate occasion, we also conducted a systematic review or an evidence synthesis on adolescent nutrition-specific interventions only. So in that exercise, we identified all the different adolescent nutrition interventions. Then we looked through what evidence is coming from high income setups and what evidence is coming from low and middle income countries, and where the evidence is actually coming from both the setups. So we not only identified where the evidence is coming from, but what were the delivery platforms for those interventions. So for example, if we look at the obesity prevention and obesity management, we identified that most of the evidence was actually coming from high income countries only, and the delivery of platform was community, school, or online media. Similarly, most of the micronutrient supplementation evidence was coming from either low income countries or low, middle and high income countries, and the platform for delivery was community or school. All right, so we have talked about the adolescent health intervention. Now these adolescents then enter into preconception phase. So we look through the different intervention that works during the preconception phase as well. So any intervention that optimizes a women's health before pregnancy with the aim to improve maternal, newborn, and child health are usually come under the domain of preconception. So we prepared a framework, and you can see here in this slide, this framework, which we developed and where we categorized preconception risk and interventions, which was actually guided by previous review in the subject area. And we conducted a systematic review of all available published, unpublished paper, and looked at and consolidated our evidence on the effectiveness of interventions to improve preconception care and ultimately improve the health of mothers and babies. So these were all the immediate, intermediate, and underlying risk factors and interventions that we reviewed in our evidence synthesis exercise. And we identified some of the effective interventions. So we can see that these are all the effective interventions that we identified, but we also identified how we can bundle up and provide them, what mechanism and what delivery platforms are ideal for the delivery of those interventions. So for example, the effective interventions that we identified were screening and management of chronic diseases, nutritional optimization, obesity prevention and management, youth development programs, including infection prevention, nutrition counseling, and completion of secondary education for adolescent girls. And then in this figure, you can see that we have also identified the ideal delivery platforms for providing those interventions to the girls or even the boys. All right, so we have talked about the adolescent intervention. We have talked about the preconception interventions. Then let's now talk about the nutrition. So there was this Lancet series that was published in 2013, Maternal and Child Nutrition series, that actually identified 10 very specific nutrition-specific intervention through the evidence synthesis exercise. So they actually conducted a series of different reviews and identified 10 nutrition-specific interventions that can improve the nutritional status of mothers and babies. And though all those effective 10 interventions are actually mentioned in the blue boxes in the figure here. So you can see folic acid fortification, micronutrient supplementation and balanced energy protein supplementation to mothers, breastfeeding, complementary feeding to children, vitamin A supplementation, zinc supplementation, management of moderate acute and severe acute malnutrition were identified as the very effective interventions to improve the health and nutritional status of mothers and babies. So this figure actually shows how much of a mortality can be reduced if these 10 nutrition-specific interventions are provided. So for example, if we talk about the management of severe acute malnutrition, it can prevent up to 350,000 deaths under the age of 5 years. If we talk about a simple promotion of breastfeeding, it has a potential to prevent up to 125,000 death under the age of 5 years. So they not only, the evidence synthesis exercise not only identified the intervention, but it also provided the evidence how many deaths can actually be prevented when these interventions are scaled up in the community. So I was lucky to be a part of the updated series. So the group of experts actually met in the Italy in the year 2019, where we discussed this update work, and we came up with the revised systematic reviews on all the different maternal, newborn, child, and adolescent health nutrition interventions. We conducted the evidence synthesis on each of those different interventions that can improve the health of mothers and babies, and then we identified certain interventions. So for example, we identified the direct health sector nutrition interventions, where that includes all those interventions that we talked about, like for example, maternal balance energy protein supplementation, maternal micronutrient supplementation, vitamin A supplementation, and so on. So we not only identified direct health sector nutrition intervention, but we also identified indirect health sector intervention, and that includes family planning, that includes maternal mental health support, which indirectly impacts the nutritional health of mothers and babies as well. We further identified other sectoral strategies that directly affects nutrition, and that includes, like for example, fortification of iodine, or staple food fortification, or social protection programs, which are not directly health sectoral intervention, but they are other sectoral interventions, but they have a direct impact on improving the nutritional status of mothers and babies. Then we also identified other sectoral strategies that indirectly affects nutrition, and that includes poverty alleviation programs, or women empowerment, or food safety nets, and all those different programs that can impact the health, the nutritional status of mothers and babies. And of course, the cross-cutting strategies that includes health system strengthening, data system strengthening, and community mobilization. All those impact indirectly impacts the nutritional status of mothers and babies as well. So whatever exercise we did to identify these interventions that I presented in my earlier slide, those were all published as a separate paper in the Lancet series. And then we separately published each of the evidence synthesis exercise in the form of series in the Nutrients in the year 2020. So the earlier series of 2013 that identified 10 very specific nutrition related interventions that can improve the health of mothers and babies, this updated exercise actually identified the 11. So one more intervention was found to be very effective over the years. I mean, the evidence was very robust to conclude that this should be included in the list of the effective intervention, and that is the preventive small quantity lipid nutrient supplements for optimizing the health and growth of children. All right, so I have given an evidence of the evidence synthesis exercise on adolescent health interventions, the preconception health interventions, nutritional health interventions. We also did an exercise where we looked at the evidence synthesis of the guidelines on adolescent nutrition. So we did a whole evidence synthesis exercise where we looked through the adolescent nutrition guidelines, and we identified that there were only 29 guidelines pertinent to adolescents or preconception, and there were 84 guidelines on pregnant women. So very few of those guidelines which were on adolescent and preconception talked about the overall adolescent health or preconception health, and many of those only limited their findings to overweight and obesity. So guidelines pertinent to women before and during pregnancy were generally derived from the general population of women of reproductive age. So through this exercise, we actually identified that there is a scarce of guidelines on adolescent nutrition. Yeah. All right, now what are the challenges in implementing these interventions that we identify through the evidence synthesis exercise if we talk about implementing those interventions in low and middle income countries? So the one is lack of access and low healthcare seeking practices in those setups. They have fragile healthcare systems. They have numerous policy, social, and legal barriers. They have lots of disadvantaged group within those setups, and many of those have conflict settings as well. As in my earlier slides, I have mentioned that a lot of deaths actually occur in low and middle income countries. So 99% of all maternal and child deaths actually occur in low and middle income countries. So we wanted to identify what are the strategies that can actually improve healthcare seeking for mothers or even for babies and children. So we again did an evidence synthesis exercise where we looked through different strategies that can improve the healthcare seeking in mothers and babies. So we conducted a systematic review where we looked through different strategies that can improve healthcare seeking. So we looked through community mobilization as one of the strategy, home visitation as one of the strategy, a combination of community mobilization and home visitation, and enhanced perinatal care or education as strategies which can improve healthcare seeking. And we identified that community mobilization alone can improve or can reduce 21% of total neonatal mortality that occurs in those settings. And community mobilization in combination with home visitation can reduce neonatal deaths by 27%. Again, community mobilization and home visitation can improve or can reduce stillbirths and perinatal mortality by 22%. So this actually, we identified the importance of those strategies through our evidence synthesis exercise. Plus, we also identified that these strategies can improve institutional births by 20% and initiation of early breastfeeding by 93%. So through our evidence synthesis exercise, we identified how we can actually improve and what strategies are beneficial in community setups. We also conducted an evidence synthesis exercise on community health workers. And earlier, when we were looking at the videos that were shown, we were able to see that community health workers do play an important role, especially during pandemic. They have played a wonderful job in not only promoting the health, but continuing with the exercise that they do in the community setups. So we actually conducted an evidence synthesis on community health worker. This we actually conducted in 2010 or 11, where we looked through the wide range of services provided by community health worker in the primary healthcare settings. We identified that the services offered by community health worker actually reduce the deaths in mothers and babies and improves their health as well. So they play a very important role, especially in low-income countries or countries with fragile health and economic systems, and the countries which are far from reaching the goals for sustainable development goal. They play a very important role in improving the health and help in meeting the targets set for SDGs as well. We separately conducted an evidence synthesis exercise on mid-level health workers as well. They play an important role in the delivery of maternal and child health services as well by providing minor surgeries in countries like Africa, providing antiretroviral therapy, health promotion activities, prevention and care for non-communicable diseases. So in our evidence synthesis exercise, we actually compare the services provided by mid-level health worker with any professional health workers, and we found that services rendered by mid-level health workers were as effective as any routine care and sometimes better than the professional health workers as well. Okay, now I have actually I took you through the different evidence coming from the systematic reviews and evidence synthesis exercise that we have conducted over the years. Now let's talk about what exactly we identified through this exercise and how we can further advance the agenda on health and nutrition of children and adolescents. If we talk about the role of evidence synthesis itself, We know that they play a very important role in the evidence ecosystem. The evidence synthesis not only improves the knowledge generation, but they help in producing and developing guidelines. They identify the research gaps, where are the research gaps, and then they provide the action plan or the agenda for further actions. So let me give you some of the examples from the work that I have done. So for example, the work on community health worker and mid-level health worker and the evidence synthesis that we done and published as a Cochrane review on community-based intervention packages actually led to the development of the WHO guideline in 2018, which was specifically on community health worker. So all of that work that we did earlier actually led to the development of WHO guideline on community health worker, how and how they can work and what evidence is there. Similarly, the other example is that one of the review or evidence synthesis exercise that we did on possible serious bacterial infection actually led to the development of another WHO guideline on managing possible serious bacterial infection in young infants when referral was not feasible. So this evidence synthesis actually talked about how we can, how effective and feasible the intervention are for possible serious bacterial infection when in the community settings and when the referrals are actually not possible. So this is another example of the evidence synthesis work that we did and how it translated into the guideline. But if we talk about the agenda for action for the work that I do for children and adolescent health and nutrition, these are the different points that I will be highlighting can improve and can take this agenda further. Number one is to adopt a life cycle that prioritizes children and adolescents, because we need to break the vicious cycle of intergenerational malnutrition, poverty, and chronic diseases. And we need to take the first 1,000 days approach, but we need to extend it to people beyond 2 years, including adolescent girls and women of reproductive age, and we need to include it in the agenda as well. And we need to take a broader lens to fully consider and address all barriers women face to achieve gender equality, health and nutritional challenges. So we need to include sexual and reproductive health as well as education as an intervention in the agenda, in the ongoing agenda to improve their health. Community involvement is very important. We need to invest in children and adolescent health and development. We need to invest in building their capacity so that they can take the ownership and charge of their own health. We need to support adolescent and young people as agents of change. We need to identify context-specific needs, including barriers to realizing rights and access to essential goods and services and information. Multi-sectoral approach, because around 50% of the gains in the health of adolescents result from investment outside of health sector. And we have looked through one of the example in the nutrition as well, that nutrition intervention itself doesn't improve the health of the nutritional status, but other sectoral intervention also play a part in improving the nutritional status of mothers and babies. So we need to adopt a multi-sectoral approach, identify and incorporate policies and interventions that affect health. We need to build governance and capacity to facilitate a multi-sectoral approach. And we need to monitor the impact to enact joint monitoring of policies and intervention in different sectors. It is very important to close the gap on our evidence and data. We need to close the gap on evidence base. We need to develop, test, and roll out solutions and address obstacles to effective implementation with a focus on the neglected life stages of preconception and adolescence. And we need to close the huge data gap. Programs should review all national policies for health data collection and find ways to incorporate a focus on adolescents, because most of the time we have seen that adolescents are not included as part of the data collection. And most recently we have seen school-age children of 5 to 9 are usually ignored. So we need to include them in the data collection as well. Health workforce and universal coverage. We need to equip our health workforce everywhere, improving their competencies, numbers, and working condition and rewards. We need to prepare health system to cope with emergencies such as we have seen recently in the COVID pandemic. We need to ensure universal coverage of essential healthcare interventions as well. So yeah, this is it from me now, and I need to acknowledge all my supervisors, mentors, researchers, senior researchers, junior researchers, students who are involved in this evidence synthesis exercise, and I need to thank all the donors and funding agencies which actually made this work possible. Thank you.
Thank you, Dr. Zohra, for such an amazing and enlightening presentation. I would now like to open the forum for questions simultaneously while we begin with a fireside chat with Dr. Soumyadeep and Dr. Zohra. So they both will be addressing the questions simultaneously, I suppose. So yeah, over to you, Soumyadeep.
Thank you. Thank you, Zohra, for the wonderful talk, and the depth as well as the breadth of this work is huge, and I can only imagine how challenging it must have been to put almost a decade of work in such a short presentation. And thank you for giving us how evidence synthesis shaped this entire domain of work. And I think one of the questions that came up in the chat as something I was actually wondering to discuss with you also is that context is a very important part of any evidence and any implementation or to achieve any impact. So when you were categorizing this evidence or these interventions into what works and what doesn't work, how important is the context, and how do you take that into account for different settings?
Okay, so all right. So when we were the first categorization actually, or obviously, we categorize based on the different domains of the continuum of care. So we categorize based on whether it is reproductive health intervention or child or maternal, or maternal health intervention or neonatal health intervention. But then afterwards, we look through the different setups where the intervention were delivered, where exactly it was conducted, what was the setup, what was the context. So we divided and subgrouped our evidence based on different contexts, and then we generated the evidence based on the different settings it was coming from. So initially, it was there was one overall evidence. Then we grouped based on whether it is coming from high income settings or low income settings, different income settings group, and then whether it was coming from rural settings or urban settings or disadvantaged settings. So yeah, we did consider all of that. And again, yes, one more, whether it is coming from community setting or facility setups as well. So we categorize based on these different contexts, and then we propose, and then presented our evidence.
Yeah, I think that's really good. I think it's actually a really good example of the power of subgroup analysis in evidence synthesis, and something which an individual study can probably never do, or even when you do narrative reviews, we tend to get past because of what we think might work or what might not work. Yeah. So, and it's really interesting to see that quite a large amount of interventions that you had identified, they work for kind of all the settings, if I understand correctly. But were there any interventions which were working in one or two particular settings or contexts, but didn't work, and then they later changed the evidence over time, or what they clubbed as promising interventions?
So are you asking for an example, if there was any intervention that was working in different settings? I need to think about it, because there were, most of the interventions were either coming from community settings, and there were some interventions that were specifically coming from facility health setups. But there were a few interventions, like for example, antenatal care. I would go with an antenatal care. So antenatal care was provided in the facility settings as well as in the community settings through community health workers. So we had different evidence, one from facility health settings and one from community health settings. So we divided based on where the evidence is coming from and what was the evidence. I mean, what was the estimate from each of those setups when they were going to the facility and when they had antenatal checkups in their households from community health workers. So this is one of the examples where we had different evidence from different settings. Yeah.
Okay, I think that's quite interesting to know. So can I ask you a bit of a provoking question, if I may ask? You have already identified some interventions which really worked, but there's still a lot of research we see still going on and even starting around those particular interventions. Do you think they are unnecessary at this point of time, or they still need to do it? What's your thoughts around that?
So are you asking specifically for the one which were ineffective at that time?
No, in general. I was asking in general. I mean,
okay. So it is important to keep on updating your evidence, I would say, because this particular exercise was initially when it was funded by WHO, was done in 2010 or 11, and this policy, I mean, this guideline came in 2011 or 2012. But then I conducted, I mean, I did it as part of my PhD project as well, which was in 2013-14. But since then, I haven't updated that. But obviously, each intervention, I mean, has been looked through several evidence synthesis exercises. But as a whole, we haven't done it, and we need to update this exercise again. So yes, obviously, some might move in the position where we have assigned them. So yeah, it is very important to update your evidence very frequently.
Thank you. And one question kind of comment from attendee was our research, like we know research on adolescent health is scarce. So how do you decide on which health outcomes to prioritize?
Which health outcomes to prioritize in terms of this whole continuum of care?
Yeah, I think that's the question, I guess. Yeah.
Okay. So there is, I know, I mean, you can further elaborate on this mechanism that I would be talking about is research priority exercise. I mean, this is one way to prioritize which intervention or which area needs to be, prioritized first. And you have done it in your work as well. This is one way of prioritizing what intervention should be catered first or at the priority, and then move along the list that you have prepared. But I mean, I don't know if there is any proper way of doing it, but this is one way of doing it. But like if I talk about in my work, we generally start with very broad, and then we look through the different interventions that can be delivered and provided in that domain, and then we start one by one. Yes, or the other way is to do an evidence gap map and identify where the evidence exists and prioritize those interventions first and identify the interventions first. I mean, the evidence first on those domains. And the gaps should be the one where you need to do your further work. This is one way.
Yeah. So broadly, I think what you are indicating is even for prioritization, whatever manner we choose to do so, there's a need for doing some non-atypical or non-typical evidence synthesis work and engaging with a variety of stakeholders. But we are running short of time. We'll end just some time, but just one of the last questions, and this is again from one of our attendees. It has been asked. I mean, first of all, big thank you for the in-depth perspective. But Do you have any, could you share any best practice models of healthcare, which is true from across the globe? And the attendee gives an example of Brazil, an initiative called Bolsa Familia, which is a conditional cash transfer program for improvements in children's school and health. So wondering, what are your thoughts on conditional cash transfer programs for the domain of work you do? And any other best practice models?
Okay. Oh, it is very difficult to identify one best model, actually. It depends, again, the context. So currently I'm working on one of the evidence synthesis exercise where we are actually looking at the social protection programs. So there are several social protection programs through which, so for example, this one that I'm doing is for nutrition. So we are looking at different social protection programs with which we can improve the nutritional status of children in community. So it depends what exactly you're looking at, what is the objective, and what is your outcome, and also what is the population. So I don't know, we are, the one that I'm doing is looking at the at-risk population, but it might be different if we are looking at the at the population where it is a problem. So there are population who are actually suffering from malnutrition, but talking about at risk, which are not malnourished but at risk of malnourishment, we are looking at whether the social protection programs are working or not. So it depends what is the context and what is the population. So I cannot recommend one best model which fits all.
Yeah, I think it's actually a good note to end on. I think we definitely, this series is about the power of evidence synthesis, but it's also about the limitations of evidence synthesis, which is essentially we can identify the interventions and how it works and how certain we are about it, if it works and in what context. But the exact nature and the model of how a system is set up is way more complex, and it would probably be very different in different contexts. So I think that's kind of a good note. We are right on time, and thank you, Dr. Zohra, for joining us and for this really great presentation on your part.
Thank you.
So, and yeah, back to you, Samiksha, for your last words.
Yeah, thank you so much, Dr. Zohra and Dr. Soumyadeep, for such an amazing fireside chat. I hope our audience has been benefited. And secondly, I would like to apologize because we'll be answering the rest of the questions via email to you all. I can see a couple of questions in the chat box, but in interest of time, maybe we'll have to send it via email. So, just quickly wrapping up with the session, I would like to remind you that we'll be having a couple of more seminars under this series coming in few months. So, looking forward to see you all there as well. And I hope if there are no more questions, we can wrap up the session for today. Thank you so much again, everyone, for joining in, and have a great day ahead. Thank you.
Thank you.